Good afternoon, everyone. It's a pleasure to be with all of you today, May 13th, 4 o'clock, for our spotlight on St. Joseph's. May, and we just had Mother's Day not too long ago, so we're excited about this topic that we have for today, and we're very excited about the panel of speakers, which is really an outstanding panel, and some of our best practitioners here at St. Joseph's Health that we're proud to feature. Before we get into our presentation, our Q&A with our panel, I'd like to thank all of our corporate champions, our donors, our friends of the foundation who have joined us today. Thank you so much, as always, for all of your support. And I would especially like to thank a member of our Board of Trustees here at the foundation, Marie Bruce, and her husband, Chuck, for sponsoring today's presentation. Thank you, Chuck and Marie, as always, for all you do for St. Joseph's Health. As I said, we have a terrific panel of speakers today. It's our largest panel that we've ever had, so we're very excited about this, and I'm sure that everyone's going to walk away with a lot of information today, and we'll have an opportunity as well for questions at the end. So please, you may use the chat function in the program to ask a question, and you may also email them to donations@sjhmc.org. That's donations with an S at the end at sjhmc.org. So without further ado, it gives me great pleasure to introduce St. Joseph's Health President and CEO, Kevin Slavin. Thank you very much. Kevin, turn it over to you.
Thanks, Rob. Good afternoon, everybody. We're really excited that you're joining us today for this extremely dynamic panel discussion on the latest issues in women's health. We've assembled a group of physicians that have been delivering babies and caring for women at all ages and all stages in their lives. They're also doing some very cutting-edge work in this state to eliminate maternal health inequities, while at the same time providing excellence in women's health care. So let me briefly introduce each of our speakers. I'm going to start with our first speaker, Dr. Roger Kearse, who's the chair of obstetrics and gynecology here at St. Joseph's Health, a position he's held since 1997. Dr. Kearse also serves as a clinical professor in the OBGYN department at St. George's University School of Medicine, and as a teacher and mentor to all in his practice and all on our women's health units. He's also been an active member of the Board of Trustees, Partnerships and Strategic Planning Committee, and played an instrumental role in helping craft our new relationship with Hackensack Meridian Health to bring enhanced oncology care to our community. With us today, we also have Dr. Megan Kaminsky, who grew up here locally in northern New Jersey and has been practicing in Montclair for the past 6 years. She offers her patients a wide range of healthcare services from pregnancy to menopause management, treating every woman with expertise and sensitivity. Dr. Kaminsky earned her medical degree at St. George's University and completed her residency here at St. Joseph's. Next will be Dr. Sarah Barber, who also trained with Dr. Kearse during her residency right here at St. Joseph's and has since joined him in their Willowbrook practice. She offers her patients comprehensive care and personal attention as a highly skilled physician with special proficiencies in high-risk pregnancy, minimally invasive surgery, and preventive care. We're also joined today by Deborah Katz, a certified nurse midwife who has served as the chief of our midwifery service at St. Joseph's since 2014. As you hear later on, Deborah has been instrumental in running our Centering Pregnancy program to help address health inequities for mothers and newborns. And finally, representing the next gen of St. Joseph's clinical leaders is Dr. Shirley Mengele, a third-year resident who will become chief resident when she begins her 4th year this July. So I want to thank all the panelists. We're excited to have you here and looking forward to your insight. So Rob, I'm going to turn it back to you to get the conversation started.
Thank you, Kevin. Yes, so our first topic of conversation this afternoon is going to be lessons learned treating and preventing COVID-19 during pregnancy. And Dr. Sarah Barber will be first up in answering a couple of these questions that we have for her this afternoon for the panel. Over the past 14 months, we have all experienced firsthand the challenge of combating this global pandemic, COVID-19. With nearly 1 million positive cases and over 23,000 deaths here in New Jersey, it's been a trying time for hospitals and health systems. Here at St. Joseph's Health, we have discharged over 4,100 COVID-19 positive patients and have witnessed the grit and determination of our healthcare providers, including our clinicians here with us today. Question: as we look at how far we have come since March 2020, what are some of the things we have learned about treating COVID-19 during pregnancy?
Hi, thank you. So this was a scary situation for all our staff because we really didn't know what to expect. We found out very quickly that our patients who are pregnant were very high risk for serious COVID infection, and we had to really take even the mildest symptoms seriously. A pregnant woman with COVID could decompensate quickly. So our team really developed a multidisciplinary approach where we work closely with perinatologists, infectious disease, and internal medicine to manage these patients with a high suspicion that they could become critical very fast. And we had to think of the health of both the mother and the baby with each patient. So we took it very seriously right away, just knowing that the demand of pregnancy on the body, in addition to this illness, would put patients at risk. On the labor and delivery floor, we started out with one isolation room and one isolation OR. And when patient cases started increasing, we had to adapt very quickly. In fact, when the surge hit, we had 1 out of every 3 patients coming into labor and delivery that were positive for COVID. So we had to really make sure we had all the proper equipment and rooms and isolation set up for these patients and to protect all the other patients. And I have to say, our nurses, the doctors, we did such a great job. Everyone jumped right in and they didn't even think of themselves. They just took care of the patients as they always did. We initially were having to be conservative with protective gear, and our nurses and doctors, the whole team really stepped up and they stored their gear, they properly cleaned their gear for reuse until manufacturing caught up, and we had to protect ourselves and the patients. So they did a really great job adapting day to day as things changed.
Thank you. Was there anything that surprised you early on about this? You know, of course, there were the initial fears and concerns, right, about the unknown, but anything unusual at the outset?
I think everyone was concerned about getting this infection and potentially bringing it home to their families. But you know, no one on our team changed how they treated the patients. They all wore their PPE and jumped right in as usual and took care of the patients. So I'm really proud of that. I have such love for the team there. You know, they really didn't waver at all, even though we were all kind of nervous about how this was going to affect us. Moms would come in and find out for the first time they were COVID positive, and this was really upsetting. We had moms crying and worried that they would not be able to hold their babies and breastfeed and bond with their babies. But our team was able to show these moms how to protect the babies and still not miss out on enjoying this whole process. Many institutions completely eliminated any support person. Our team continued to allow moms to have one person with them during labor, delivery, and the postpartum process. While making sure everyone was wearing all the proper gear, we still maintained safety for the patients. So we were learning as we went along, receiving information on this virus as it came available. But we really provided good education to our patients, had very good outcomes, you know, with what we knew. And I think our team did a really great job following the guidelines and keeping everyone safe, but at the same time, not forgetting that human aspect where we realized that patients still needed that support person to go through this major process with them. So I'm really proud of how everyone took this situation seriously, but didn't waver in patient care.
Wonderful, wonderful. No, and we've heard through the foundation, we had such good feedback from family and friends that all the wonderful care all of you were providing. So thank you for doing that. The approval and distribution of the COVID-19 vaccine was for many people, right, the first sign of hope. And as of last week, there were over 3.3 million people fully vaccinated in New Jersey out of the state's 6.9 million adults. When the vaccines first became available, there was some uncertainty, right, about whether pregnant women should receive it. Individuals who are pregnant are eligible for COVID-19, the vaccine in New Jersey, but are advised to first discuss with their medical provider before receiving the vaccine. As a medical provider, what are you seeing among, the consensus of your patients? What would you suggest to a patient who is pregnant that might be hesitant to become vaccinated?
Yeah, so it was like 50-50, patients were hesitant. Those were the 50% were hesitant and the 50% who, didn't trust the vaccine. I think that how quickly they were able to produce the vaccine was the most concerning to patients, as they thought that this somehow related to being less safe than other vaccines. Then you have the patients that have a negative view of vaccines in general. So I tried to educate the patients that the vaccine is safe and all the proper steps were made in the rollout of these vaccines. We know how the vaccine works, being a protein that stimulates the immune system as opposed to a live virus. And we know how the body's going to respond. And I try to inform my pregnant patients that pregnancy alone puts them at a higher risk of severe illness, which has serious implications for themselves and their babies, as opposed to a non-pregnant patient.
Very good. So I was going to ask you a follow-up question about sort of the effectiveness of receiving the vaccine while pregnant. And to your point, I mean, they're at a riskier, in a riskier state, so to speak, is what you're saying. So it's really, you would advise it, correct?
Yes, I advise it. I mean, the Moderna Pfizer vaccine, they're 94-95% effective in preventing severe COVID illness, just as in a non-pregnant patient. And, we're starting to see in the studies of umbilical cord sampling that antibodies that the mother makes from the vaccine are present in these samples, which may imply that babies could be getting the antibodies from the mother, which is a good thing. Same with breastfeeding. These beneficial antibodies are passed in the breast milk, which is why we breastfeed, in addition to providing nutrients for the baby. So we're seeing positive effects of the vaccine in pregnancy, and that's why, we've been comfortable recommending it to our pregnant patients.
Wonderful, wonderful. Well, thank you very much, Dr. Barber. We'll come back to you later in the presentation for some follow-up questions. We're going to move on to our second topic this afternoon, which is combating health inequities and racial disparities, centering pregnancy program, and more. And we have Dr. Mengale and Deborah Katz, two of our panelists who are going to address these particular questions. And the first one is, the pandemic clearly revealed the many health inequities that exist, especially among the Black and Brown communities. And when discussing OBGYN care, we know that a range of biological, social, environmental, and physical factors have been linked to maternal, infant, and child health outcomes as well. And as well as socioeconomic factors such as race, ethnicity, age, education attainment, income level, medical insurance coverage, access to medical care, pre-pregnancy health, and general health status. We also know that pre-pregnancy health behaviors, health status are heavily influenced by a variety of environmental and social factors, such as access to prenatal care, chronic stress, and some of these factors can affect and compound others, creating a rippling effect. First question, what is St. Joseph's Health doing to improve pregnancy health behaviors to improve the overall health of our community, namely through our new Centering Pregnancy program.
I am so excited about the Centering Pregnancy model of care. We've been on this journey for just over a year now, and we started a month before the pandemic. Centering Pregnancy is a group prenatal care, bringing women due at the same time out of the exam room and into a comfortable group setting. It follows the recommended schedule of 10 prenatal visits, but each visit is 90 minutes to 2 hours long, giving women 10 times more time with their providers. Moms engage in their care by taking their own weight, blood pressure, checking their urine, and recording their own health data with having private time with their provider for their belly checks. Once the health assessments are complete, the provider and support staff circle up in a room with the moms. They lead facilitative discussions and interactive activities designed to address the important topics and timely health topics, while leaving room to discuss what's important to the group. Centering materials help moms and providers ensure that everything from nutrition, common discomfort, stress management, labor, delivery, breastfeeding, and infant care are covered in group. We're meant to be in conversation with one another. Centering Pregnancy brings 8 to 10 women all due at the same time together for their care. Providing care in this way allows moms and providers to relax and get to know each other in a much deeper and more meaningful way. This extended time allows us to have conversations about health, about food scarcity, about housing insecurities, family dynamics. All of these impact healthcare outcomes. One person's question is another person's question, and patients quickly find comfort knowing they're not alone. Participation in group care lessens the feeling of isolation and stress while building friendships, community, and support systems. Members of the group form lasting friendships and are connected in ways not possible in traditional care. Centering groups comprised of women of different ages, races, socioeconomic backgrounds see these differences diminish in importance as they share the common experience of pregnancy, birth, and family care. 10% of all U.S. babies are born premature, and that was in 2018, and that was increased for 4 years in a row. And Black women have a risk double of white women. And the cost of preterm birth and related conditions is more than 10 times that of a healthy baby. Numerous published studies show that centering nearly eliminates racial disparities in preterm birth. And that's the reason we started this program. The centering moms are better prepared for labor, delivery, and for care of their infant because they understand the normal and they know what is cause for concern. While our centering numbers are small, we're already seeing positive results. Our vaginal delivery rate is 82.6% compared to the hospital rate, which is in the low 70s. And our preterm birth rate is lower than the national average at 6.5%.
That's excellent. Thank you, Deborah. Is there anything, Dr. Mangala, you wanted to add to that?
I think Deb covered it pretty well.
Very good, very good. So as a follow-up question to that, while this program launched around the same time as COVID-19 started, what are some of the initiatives we're looking to add or expand to further grow and develop these outcomes?
So up to this point, all of the centering programs groups have been English speaking. When we've recently had a Spanish provider take the training, and we're going to be starting Spanish groups next month. So we'll have 2 groups for each delivery month going, one English and one Spanish. We also have plans to incorporate the high-risk OB clinic into centering and are currently in talks with other hospitals and the Centering Healthcare Institute to assist us in this transition. And as the COVID precautions are lifted, we plan to grow in the size and the number of our groups.
Excellent, excellent. Thank you, Deborah. So not only is the topic of health inequities being discussed on the national level, but locally, of course, and it's a priority of our governor here in New Jersey and the First Lady as well. They've made it a priority to develop initiatives around maternal, infant, child health. And here at St. Joseph's Health, we've received both state and private funding. We're very pleased to have as supporters the Burke Foundation, the Nicholson Foundation, and others that have been supporting this work, and to be able to strategically align ourselves with other organizations such as the Healthcare Coalition of Passaic County, also known as HCPC, and the Partnership for Maternal and Child Health of Northern New Jersey. Recently, through a collaborative partnership between St. Joseph's Health, our foundation, as well as the St. Joseph's Health Innovation Center, and the HCPC, we received funding through the Henry and Marilyn Taub Foundation and the Terrell Fund. We're focusing even more on these preterm birth rates through the lens of the racial disparities that exist. We're very pleased to have this funding and to be able to focus on this area. The question is, can you speak more about the maternal and infant health crisis in New Jersey and how the Undoing Racism workshops have empowered you as a clinician to address this issue?
Yes, so to give everyone just an overview of the numbers, unfortunately, Black women, Black and brown, but mostly Black women are about 4 times more likely, 7 times actually more likely to die either during or after giving birth. New Jersey, unfortunately, has the 4th highest rate of maternal morbidity and mortality in the country. And so given that, and given the First Lady's New Jersey initiative plan, and the fact that we were able to do the Undoing Racism workshop, I think it was a perfect time for everybody in the healthcare system, not just the doctors, not just our CEO, not just our attendings or our nurses, but from the MAs, the people who meet the patient first, right, to the people who see the patient last. We're able to have a conversation about what we know and what we don't know. And I think that the workshop that we did on Undoing Racism was important because we addressed all the categories that exist in which racism can exist, apart from the racism itself. And people were able to discuss and learn. And I think that one of the things I hope everyone took from it was whenever you see somebody, a patient, their family member, you have to see them as the whole picture, right? So not just the disease that's walking towards you, but the patient's home life, the patient's existence under racism, because that in itself is a reason for the high risk pregnancies that they undergo. So their socioeconomic status, do they get transportation to the hospital? Are they scared, that they can't get any food, or they're scared that the baby's father won't make it, through the week because they're afraid they're gonna die. All those things are walking into your office as the patient is walking into your office. And I think that that's something that the Undoing Racism brought to us, is the awareness of all those things surrounding that one patient that we see in a day, and all the others that we see. So I think it was a very important workshop for us to undergo.
Excellent, excellent. Is there, these partnerships that I mentioned that are helping us to focus in this area and to be present in the community addressing these issues? Is there anything, sort of something that jumps out to you in particular that stands out that is important in order for these partnerships to succeed?
I was talking with Deb, actually. We were having a great conversation yesterday, and we were just talking about the programs that probably, a lot of people don't know about. There's a new program that's trying to create an app actually for St. Joe's pregnant women, so that we as the doctors and them as the patients can monitor their pregnancy throughout their pregnancy, so they can, watch their gestational age, talk about things to look out for. And I think things like that are what are going to entrench us into the community, because the community then knows that we're watching out for them. We want to know what's going on with them, not just the pregnancy, but everything else that they're going through that will affect their pregnancy. And I think that the community needs to know that we are here to be with them. We're not just here as a hospital, but we're here as the community with them. And I think that apps like these and Undoing Racism and panels like this are opportunities for us to show them that we're here, to be here for them, not just as their doctors, but people who support them in all aspects of life.
Very good. Thank you very much, Dr. Mangali. Thank you, Deborah, as well. Go ahead, Deborah, please. Go ahead.
So I just want to share that this program was a taste, a teaser. And regardless of race, we all have to do our own work. We all have to learn our history and look into ourselves to see where our own unconscious biases are and address them, and be willing to accept constructive criticism, all in the goal of becoming a safer healthcare institute.
Absolutely. Thank you, Deborah. 100% agree. Thank you very much. So we'll come back to you all in the Q&A section. We're going to jump to topic number 3 of this afternoon, which is entitled Beyond Pregnancy, Gynecological Care for All Ages. And we have Dr. Megan Kaminsky with us. So beyond pregnancy, we all know that it's very important for women to seek gynecological care on an annual basis. A study from 2013 predicted that the national demand for women's health care was forecasted to grow by 6% by 2020, and we've seen that the demand for gynecological care continues to increase. Additionally, according to the American Cancer Society, there were approximately over 110,000 new cases diagnosed and approximately over 32,000 deaths from gynecological cancers in the United States in 2018. Can you share with us the recommended preventative care for women in their 20s, 30s, 40s, 50s, and 60s and beyond? I'll mute.
Hi.
We hear you now.
Start out with discussing screening just in general. When we talk about screening and preventative care, we're talking about catching the precursors to cancer or catching cancer in the early stage. Normal cells don't just turn to cancer, and it doesn't happen overnight. It's a stepladder approach. So, over time, these cells and these precursors start to become, more aggressive, which then kind of turn into cancer. So it's these precursors that we screen for, and these precursors where we can intervene and prevent malignancy from happening in the first place. And if it's found, that it's found in early localized disease, and obviously treatment is much less, invasive when we diagnose early disease. A pap smear is going to be a woman's first kind of preventative screening that's done. That starts at age 21, regardless of onset of sexual activity, and goes until the age of 65. These recommendations change depending on risk factors, and the biggest risk factor being the HPV infection, and not specifically just HPV, but specific strains of HPV that we know can lead to over 90% of cases that lead to cervical cancer. So when we do pap smears, at 21, if your pap smear is negative, the recommendation is to receive pap smears every 3 years. At age 30, we look at your cells, we also look for HPV, and pending that all those results are normal, the pap smear can actually be extended to every 5 years. However, that does not mean that you should be only seeing your GYN 5 years. You still are recommended to see your gynecologist yearly for your breast exam, abdomen exams, and a pelvic examination where your uterus, your ovaries, and everything else are going to be palpated to make sure there's no abnormal growths or anything else going on there. And specifically speaking on HPV, we also have the Gardasil vaccine. So that can be given as early as 9, usually It's given between the ages of 11 and 12. And again, vaccination is prevention. By giving the vaccine provides, immunity to the most common strains that lead to cervical cancer as well as genital warts. So by getting, your child that vaccination, you're talking prevention, which again is the most important thing. I read actually today in the Today newspaper, there was an article that stated because of the COVID disruption and people not seeking the normal screening and normal doctor appointments out of fear of COVID, they estimate an increase of 10,000 preventable deaths from colorectal and breast cancer. So I think that number is astounding. That's 10,000 preventable deaths. That's your mother, your grandmother, your sister, your neighbor, your friend. And again, we're looking to screen and catch this early disease and these precursors. From there, the next screening test is the mammogram. It's recommended that we start at age 40. Again, these recommendations change depending on personal and family history. But for the general population with risk factors, we start at the age of 40. Some people are kind of reluctant to start. You should definitely have your first mammogram by the age of 50. It's been shown to decrease the breast cancer rate. Greatest is the age range of age 50 to 74. It's an annual test that you have done. So again, that can change depending on the results of your last mammogram, if your personal or family history changes. But again, that's an annual screening test that is done. And I counsel all my patients, when they come for their exam, to practice what's called breast self-awareness. So, your breast is normally, lumpy and bumpy. So just knowing, what abnormalities are there and what is different. Is there a difference? Is there a change? And seeking attention when you notice that change. Just knowing your body and knowing, yeah, I've had that lump, it hasn't changed for the past 15 years. Or you know what, this feels different. This is concerning to me. I should go check out. So I think, again, that self-awareness is very important. And then, starting at age 65, we start screening for osteoporosis. So, again, depending on risk factors and everything else, a woman will go for a bone scan. And, that bone scan can test, does she have soft bones or is she leading towards, osteoporosis, where we need to initiate treatment and things like that.
Very good. Very good. Thank you, doctor. Well, you touched upon my second question was going to be about exactly what signs or symptoms for some of these cancers that you've spoken about, or that women should look for, that should prompt them to seek immediate care with their OBGYN. Do you want anything additional you want to expound upon with that? Any additional encouraging words? Because like you say, I know many women just delay. They don't want to, they just don't want to go there, right?
Right. The biggest thing is just knowing your body and knowing a change. For cervical cancer, we look at, are you having bleeding after intercourse? Are you in menopause and now you're having postmenopausal bleeding? Are there any other changes? Are you having, abnormal discharge or anything like that? For breast, like I said, it's just noticing a change from there. Are you having any, bloody nipple secretion or different discharge from your nipples, or anything that's kind of different from there?
Okay. Very good. Very good. Thank you. Thank you very much, doctor. We're going to jump to our fourth topic and sort of the final topic of our panel, and then we have some questions that are already coming our way for the group. So I guess we saved the best for last, in a sense. We have our chair, Dr. Kearse, who's going to speak here. He's going to address topic number 4, which is continuing excellence in care, the renovations to St. Joseph's Women's and Children's Pavilion. I'm very happy to share with everybody. I had the privilege to go over and and be present for the ribbon cutting of our new mother-baby unit, and it's a phenomenal facility. It's just really outstanding, top-notch facility, and very excited that we have this here at St. Joseph, that we have the latest and most modern facilities to care for the mothers and babies that come to us. So this is an investment that the health system is making. It's a $55 million investment that we're transforming our facilities here in Patterson. We're creating a women's and children's pavilion. And many of these funds are coming from our Higher Commitment campaign, the campaign for St. Joseph's Health. So I again thank and want to acknowledge all of our friends and supporters and our corporate champions out there who have already contributed, especially to this particular project, and made this project, one that is continuing and ongoing, but we're able to push forward through even through the pandemic. So Dr. Kearse, can you share with us some of the vision for these new units that are going to be built, that are underway, those that have been built, and how these changes will impact the patients that you and your team care for?
Sure. So I first came here in 1985 as a student, and I was impressed with the care that was given. And the facility was a little bit old, but the care was was amazing. And in 1991, we renovated what we thought was state-of-the-art maternal child. That was 30 years ago. Shortly after that, we ended up having several hospitals in Passaic County closing. Our deliveries went from 2,500 per year, which was what the unit was built for, to 3,500 overnight with the hospitals closing. Other unforeseeable things like cesarean section rates going up and all those other kind of problems ended up developing. So we were pretty much in a bottleneck, and we outgrew the space by the mid-90s. So as Sarah Barber alluded to before, we're a can-do, will-do attitude type of department. And in obstetrics, we can only have one option, and that's healthy outcome for mom and baby. Failure is not an option. So we found ways to make it work, but it was not ideal. We were back-to-back in waiting rooms. We had semi-private rooms on postpartum, and it really was not beneficial for bonding for the family unit and all sorts of other things. And then in the process of all this, as we were planning it, COVID came along. And then all the concerns about social distancing and people being positive in a room with somebody that's negative, and semi-private rooms and new babies, it had the potential for an absolute disaster. So thank goodness we were on the curve for developing these new units, and the first unit that developed and was put into place was the postpartum unit, and it has completely been gutted from the drywall up, and we have now 26 private rooms that have all sorts of amenities, all natural light coming in, a room for the father, a bonding experience for the family, the privacy that you need to do skin to skin and breastfeeding in a safe environment. So that was the first one, and we just opened it a couple of months ago. I think it's probably 6 weeks now. And the timing is perfect because nobody in the world of COVID wants to be with a roommate when they're in a hospital with a newborn baby who's precious to them. So that has been phenomenal. And the current administration with Kevin Slavin, the foundation with Rob, and with all the other administration have really gotten behind this concept of moving maternal child health to a premier place within the institution. 5 administrations I have worked with. This is the first administration that actually had me draw the drawing plans and follow through. The other 4 administrations, we drew the plans and we never followed through. So I said I would believe it when the sledgehammer went into the wall, and I was given the sledgehammer back a year ago to knock down the wall up on the 5th floor. So that's gorgeous. In addition to that, this now allows us, as medicine has changed over the years, it has allowed us to have more space within the hospital. Most cases that were done in gynecology were done as an inpatient with stays of 2 to 5 days. Now those same cases are done minimally invasive and they go home in 2 to 3 hours. So there's a lot more space in the hospital that we can actually renovate and do these changes. Next on is going to be the antenatal testing unit. We do about 20,000 visits per year in this unit, and we have 6 technicians working simultaneously with the perinatologist all day long and also on Saturday and Sunday. This is a first entrance point for people into the hospital, and so in order to see it in a positive light, they have to have a positive initial experience, and this will allow us to do that. Once we get that moved over to another floor and another setting, which is in close proximity but not on top of labor and delivery, then we can start renovating labor and delivery, and we can actually design it, which we have, to accommodate the volume and growth so that it's a positive experience and not a bottlenecked experience, which it is now. Once we do that, then we can move the antepartum floor, which are all our complicated pregnancies, down to the first floor. Currently, they're on the 4th floor. So these complicated high-risk pregnancies will be in close proximity to labor and delivery in case these pregnancies turn sour overnight and need to be transferred expeditiously to labor and delivery. And last is the NICU. We have a premier NICU, neonatal intensive care unit, but this neonatal intensive care unit is occupying about 1/3 of the space that it should be based on the volume and based on the needs of the family to deal with the new bonding and the transition from a special care nursery with intense needs to a lesser care and a more transition to the outside world and discharge. And they're going to take up an entire floor. So this process is well underway. It's well designed. Facilities is changing the infrastructure and building the infrastructure to support all of these new endeavors. And we certainly appreciate all the donors' money that has gone into this. We've only spent about 20% of what we need to actually spend, so we certainly need some more dollars, but it has been a phenomenal experience, and it was well worth the wait.
Thank you, Dr. Keir. So I think with that, we're going to actually show, we have a very brief video that we created after the ribbon cutting. So we can roll that, and I think we'll see Dr. Keir with the sledgehammer.
Hello, I'm Robert Boodleman, Vice President, Chief Development Officer of the St. Joseph's Health Foundation. I welcome all of you to our ribbon cutting for our mother-baby unit. This project would not be possible without your support. I thank all of those who have contributed, and I look forward with your help to continuing this amazing project, which will result in the foundation of our new Women's and Children's Pavilion.
So excited to be here today for the opening of this brand new unit. As you know, we experienced a year like no other this last year, but it didn't stop the great team here at St. Joseph's for continuing the construction of this unit. Nothing got in the way of moving this project forward. We have the physical environment that really matches the care, compassion, and clinical excellence that we deliver here at St. Joseph's. This mother-baby unit is the first completed element of our $55 million Women's and Children's Pavilion. On behalf of Kevin Slavin, our Board of Trustees, and the Foundation Board of Trustees, I want to thank everyone who's been involved in this project. The mother-baby operational team, the construction team, and of course all of those donors who've provided the support to help make this construction project possible, and have joined me in supporting a higher commitment, the Campaign for St. Joseph's Health.
We know that the excellent care that our staff provides to our mother baby and babies currently will only be enhanced by this new space. With the 26 private rooms, the natural light, and plenty of space for education, we know that we'll provide our moms and babies and families with the best care possible. So congratulations to everyone who is part of this project, and we're looking forward to filling up the space.
I am Dean Emelo, Chair of the Foundation Board at St. Joseph's Health. On behalf of the Board of Trustees, I would like to thank all the supporters who made this possible.
Final thoughts, Dr. Kearse, after seeing the short film?
Well, I got to tell you, the patients are ecstatic about it because it is better than a Hilton. It's a gorgeous facility, and it just caps off the birthing process. You know, it's interesting in today's society, the expectation is a perfect outcome in terms of health. And so when people come to a hospital, they want to know, well, what else am I going to get? And if they ended up in a semi-private room after giving birth and they're sharing their newborn experience with another family, it's going to take away from the process. And so the fact that the patients have finally got what they deserve with this gorgeous unit is fantastic. It allows the nursing staff to adequately care for the patients in the proper space so they're not climbing over all sorts of luggage and clothes and bassinets to get to the patient. So there's plenty of room on an individual basis. And the physicians are ecstatic because we no longer have to fend off questions about what kind of room are you going to get me once I deliver the baby? Am I going to have a roommate? It's a concern. It's an ongoing concern. And it's a stress factor on the physicians when they drive to the hospital with their patient in labor, wondering not so much about the delivery. They know they have that handled, but where are they going to be after they deliver? And now that whole layer of stress has been removed. So from the patient's point of view, the staff and the providers, it has been a win-win all the way around. Like I said before, it has been well worth the wait. It turned out better than expected, and everybody is positive and happy about it and can't wait to see the rest of the development of the maternal child building.
Wonderful. Thank you, Dr. Kearse. Thank you very much for that. So that brings us to the conclusion of sort of our formal panel discussion, but we've had questions that have been coming in. So we're going to move to the Q&A, and I'm going to start off for Dr. Barber. There's a question here that says, are there any COVID-19 symptoms that pregnant women would experience more than non-pregnant women, and vice versa?
I think the scary thing about pregnancy and COVID is they tend to start to experience the same symptoms, fatigue, loss of taste and smell, a little bit of shortness of breath, things like that. So the problem with pregnancy and COVID is that it just happens very quickly because of the demand of pregnancy on the body. So the symptoms start out similarly, but a pregnant woman could decompensate much faster than just a healthy non-pregnant person.
Okay. Thank you. For Dr. Kearse, are all the rooms in the new center going to be private, or is that just mother and baby unit?
Mother baby, definitely, they're all designed to be private. As far as the antepartum, because of the way medicine has changed, we anticipate all of those also being private. There is a swing capability to make them semi-private in terms of a crunch. I mean, there was one day not too long ago where we had 21 deliveries in one day. The average is usually about 8, right? So, things happen. You have to be adaptable, but I would say that 99+% of the time, all of the beds in all of the new units will be private, and obviously labor and delivery. So that really just leaves the antepartum, and 99+% that will be solely private unless we have the blessing of that many people in the hospital at the same time wanting to give birth. There has to be some degree of adaptability in the world.
Wow, absolutely. That's outstanding. You hear about the declining birth rate, but it's good to know that here in northern New Jersey, people are doing their part to keep it up. So excellent, excellent. For Dr. Kaminsky, what are the top foods you recommend to add to your diet when pregnant? And are there any foods in particular to avoid?
So top foods during pregnancy, honestly, you just want to try more natural foods than processed foods. Vitamins, foods rich in vitamins and minerals, folic acid, you're going to be taking your prenatal vitamin, that has folic acid in it. But the biggest thing to avoid is usually the biggest rule is anything raw. So no sushi, nothing undercooked, no meats undercooked. Make sure your fruits and veggies are washed really well. No deli meats because of the risk of, there's a certain bacteria that can be in deli meats, and nothing that's unpasteurized. A lot of fancy cheeses, nowadays, everything tends to be pasteurized. But even if you go to certain farmer markets and things like that, they even have orange juice that's unpasteurized. So when something's pasteurized, it means that the heat kills the bacteria off from it. So anything that's unpasteurized still can have that bacteria that can be harmful to the baby. Caffeine, you limit to one, regular coffee-sized cup a day. And if you like seafood, try to stick with, salmon and things like that have a lot of healthy omega acids and things like that in it.
Very good, thank you. For Deborah Katz, there was a question about, we're doing this training, the Undoing Racism. The question is, are you providing training opportunities for other community partners using this model?
We are. We're now we've done all of the providers, and now we're going out to the staff. So nurses and community members together are doing the training together.
I just want to add to that. These were tasters basically for 5 hours, and it's really just to wet your whistle and let you get a handle on what you really don't know. And then we now are doing our first 18-hour workshop. It's 3 days, 6 hours, with half the partners being community members and half the partners being St. Joe's. So we have administration, we have clinical, and we also have our community partners that are all going to come for this 3-day conference workshop to undo racism. So yes, I mean, we've made it mandatory for the entire Department of OBGYN, but beyond that, we realize that if we don't bridge the gap with the communities, we are never going to get to where we need to be. So we have started that, and that's next Tuesday, Wednesday, and Thursday. And hopefully that's the beginning of a grassroots experience that really improves everything.
Excellent, excellent. As a follow-up question to that, it says we spoke about care of pregnant women, especially the inequities that exist. What services are available to women in our community who aren't pregnant, and especially those that are underserved, that are in the same, that are facing the healthcare inequities?
Well, even though we're focusing on maternity, the partners that we brought around the table are really family services. I mean, time doesn't allow, but we have a whole opioid use disorder affiliation where we deal with Straight and Narrow and Eva's Kitchen together with our perinatologists, but then these patients have issues before they get pregnant, and they're going back to the non-pregnant state, right? So pregnancy is only a temporary part of their life, and addiction services, the average person is addicted for 5 years if they're able to kick the habit. So by having community partners around the table, then there's an ease of transition of care and accountability to take care of these patients. So that would be one example. Eva's Kitchen to take care of people. We have battered women that are taken care of in the community. We have youth and family services that help to take it with the goal to make it an intact, healthy, prosperous family unit. And pregnancy is an important part of that, because if you start off with a good pregnancy and a good outcome at full term, You've really started with all the faculties that you really need to succeed in life, and then you need to have the ability to prosper after that with the needs of the community. So there are plenty of resources there. And one of the nice things about this Undoing Racism and joining with the community is that we also learn their side of the story and what's available for them, because we don't always know all of the resources, right? We want people to come to the hospital, but the new mentality is, how do we get the hospital to the people? How do we get the care to the community to make it a healthier environment? And we have to be seen as a trusted partner. There's no way you can do that unless you get community leaders that are advocates for the community, that educate us, see what their issues are, see what our issues are, and see where we can start knocking down some of these barriers and start treating people like people and giving them the best care they can possibly get in all aspects of their life and all the opportunities. You know, one of these workshops is one of the facilitators said, you know, why do we cheer when, you know, one black kid from the ghetto makes it and goes to college? Why shouldn't the expectation that every kid that's in the ghetto gets the opportunity to grow up and have a prosperous life, right? So celebrating that one person did it, I mean, that's great for that one person, but as a community as a whole, it's not moving the needle anywhere. So we have a lot of work to do. And, you know, I'm just at the part in my life that says this is something that's important. I don't know where I was in grammar school and high school that it just didn't strike me the way it does now. But when you look at the 400-year history of the racism that's gone on in this country, it's disturbing. And it's time to make a serious effort, person to person, to start building the bridges, building the trust, and making life better for our community.
Well, thank you, Dr. Kearse. Yes, I couldn't agree with you more, and thank you so much for your leadership on this, and the rest of the panel. Thank you all for sharing your expertise with us this afternoon. It's really been enlightening. We've gotten a lot of great takeaways from this today. So, again, I want to thank you, Dr. Kearse, Dr. Kaminsky, Dr. Barber, Dr. Mengale, and Deborah Katz for being with us here today. We're very, very grateful, and the foundation is very grateful to work with you and vice versa, to be partners in this effort. So I want to thank all of those who attended this afternoon's Spotlight on St. Joseph's. We're very grateful that you chose to spend this past hour with us, and want to remind you that we will be sending out the recording of this presentation to all the attendees. We'll also have the presentation available for viewing on our foundation website. When that is up and ready, we will let everyone know that as well. But again, thank you all for being with us here today, and wish you all a great rest of your day. Take care, and we look forward to seeing you all at our next Spotlight. Thank you very much.